Shock is higher only in the context when comparing how the person will present when they have shock. We have different type of shock. We have septic shock, cardiogenic, hypovolemic shock, distributed shock, and different morphological changes with shock. In septic shock, you just got to understand that this is dealing specifically with some kind of a infectious cause. For me, I just like to keep it simple. Infectious causes such as gram-negative bacteria have different makeup on their wall that leads to septic shock. And septic shock, essentially, in terms of physiology, is endothelial retraction. When endothelial retracts, it allows for a lot of proteins and blood and everything to leave the vasculature and lead to profound hypotension. So they will present with flushing of the skin, they will be warm, the heart. Then the management for septic shock, essentially, you want to first do a blood culture, draw the person's blood for culture, consider giving the person IV fluid immediately, and then giving them antibiotic in that order. So when you're drawing blood, you have to draw like 2 different blood from like multiple sites to culture this bug to know what it is so that you can treat it properly. Then we'll move on to cardiogenic shock. Basically, there's something affect the heart that lead to shock. MI is one of the cause of cardiogenic shock, pulmonary embolism, or things outside of the heart which may also squeeze on the heart. So like pneumothorax, for example, can cause extrinsic cardiogenic shock. And you can have pulmonary embolism, for example, which can cause extrinsic cardiogenic shock. Then you have hypovolemic shock. This is the most common shock and it's heavily tested. Person who has severe hemorrhage is very, very important to remember that. Those who have burns is very important because they're losing a lot of fluid. Of course, fluid loss is the ultimate goal that lead to hypovolemic shock here. Person may have vasoconstriction, the skin will be cold, it will be pale, it will be clammy. All that is telling you that they are losing a lot of volume. Then you have distributed shock, which essentially has to do with anaphylactic shock and neurologic shock. Neurologic shock, just simply think something is affecting the spinal cord. So spinal cord injury, person dropped from 20 feet from the stairs or something, they may precipitate neurologic shock. Anaphylactic shock has to do with mast cells degranulation. This is a phenomenon that has to do with IgE and the person getting something in their body that they're allergic to, bee sting or something like that, may lead to anaphylactic shock. Morphological changes, we're saying that the shock can have an effect on the body. As far as the heart is concerned, when there is shock, the heart has to compensate in some way. Tachycardia usually seems to be the most common response here. Unless the person is dealing with cardiogenic shock where there's massive cardiac contusion, then the person may have a heart that is not functioning to its optimum. This is where the cardiac index comes into play. Kidneys can be affected in most people with hypovolemic shock. When it affects the kidney, it can lead to intra-renal azothemia. The lungs can be affected as well, especially if you're talking about pulmonary contusion. The capillary beds and such can be affected. GI system, when you have shock and you have hypovolemia to the GI system, can lead to ischemia. Ischemia is the number 1 cause in the GI system for melena, which is dark blood in the stool. The adrenal glands can be affected by shock, especially when we're dealing with gram-negative sepsis. In this case here, we're talking about Neisseria meningitis. It can affect the adrenal glands somehow, and all the adrenal content which can be released can lead to Waterhouse-Friderichsen syndrome, which can lead to massive shock. Then we have liver can be affected too. The liver is very strong, but in cases where it gets necrosis and such, you can have fatty changes in the liver, you can have different things, formation, then if the pancreas is affected in terms of shock, the pancreas can lead to acute pancreatitis. Saponification is something that happens, is a form of necrosis that happens in the pancreas. Then if the brain is affected, basically you're talking about last result. Right? The brain, when you're talking about signs and symptoms of shock, it is a vital organ that must be fed. So therefore, if there's hypovolemic shock, the brain will be the only place that's fed with blood and everything else may shut down. Keep it simple, silly. You don't have to memorize all the details here. You just need to know their clinical relevance and you need to apply it. That's vascular diseases. Everything is fair game for the exam. As such, we're going to talk about infections of the heart. The myocarditis as well as endocarditis. Myocarditis is not extremely high yield for pathology on an exam. You have fungal infection such as Aspergillus. You have bacterial infections which deals with Coxiella burnetii, psittacosis, as well as C. diphtheria. These are all bacteria that may affect the heart, and that's more detail when you deal with microbiology. Parasitic infection, also like trichinosis and stuff, can cause an effect on the heart. In terms of the giant cell myocarditis, you deals with autoimmune diseases of the heart. Some of them may have granulomas and such. And then the viral infection is the one that's most high yield in terms of myocarditis. The most common is Coxsackie virus. We have A and B. Both of them can have an effect on the heart, but most so B is the one that's actually the most common. A, it's really associated with aseptic meningitis as well as hand, foot, and mouth disease. So that's where you will get the bulk of your questions from that end. Note that in terms of causing dilated cardiomyopathy, it's usually Coxsackie B. Then the clinical features for most of these viral problems of the heart that leads to myocarditis, it's usually a vague symptoms. The patient will present with signs and symptoms of like a flu. So you know that mostly they will be testing the viral etiology of myocarditis. Usually, if it's signs and symptoms like the flu, it's usually self-limiting. Complications are very variable. You have acute cases where it may lead to acute heart failure. You have chronic cases where the viral etiologies can lead to congestive heart failure in a chronic case, and sometimes it may lead to arrhythmia. Again, I brushed through all of this stuff because that's exactly how you should study for it. It's not extremely high-yo, but just having some background knowledge is important. The key thing to note is that if you read your clinical vignette, whether it's on the Q-bank or on the exam itself, they are going to present myocarditis in the most vague clinical vignette. It seems that the person had signs and symptoms of the flu. And so if they give you a chest x-ray, you may see that the cardiac silhouette might be very, very large. So that's a hint that the person may have myocarditis. The only other specific place you will see this is when dealing with dilated cardiomyopathy, and Coxsackie B virus can cause this. Endocarditis essentially has to do with the infection of the endocardium of the heart. You have acute causes of endocarditis and subacute causes. But let's talk about the infection first. In the endocardial space, when you deal specifically with infection of the heart, the key thing that will be tested is, one, your knowledge about the Jones criteria, and two, some of the signs and symptoms that are presented and how to treat it. In dealing with endocarditis, you must know your criteria. There's a major and minor criteria. So some people memorize the total number of majors versus minor. It's not that important, but just knowing them in broad strokes may help you to answer any questions that deals with infection of the endocardium of the heart. In terms of the major criteria, you have polyarthritis. Read your clinical vignette very carefully. So they will say the child has some kind of a pain sensation in their bigger joints, and then 3 days later, it leaves that joint and it went to another joint, simply meaning that this is a migratory arthritis. It goes from one joint to another. The next one is carditis, which is inflammation of the heart. This carditis symptoms mimic congestive heart failure. So watch out for a younger child, maybe a 16-year-old child that presents with signs and symptoms of heart failure, which is not characteristic. They may have shortness of breath, they may have rubs, they may have murmurs. They may also have subcutaneous nodules, which is also something that appears in the wrists, in the elbows, and in the knee. The individuals may also have erythema marginatum on the skin. These individuals have areas that appears on different parts of their body that's worse with heat, and it usually tends to spare the face. Individual may also present on a later state with Sandihan chorea, which is basically a choreiform movement, kind of like the chorea disease, but in this case, it's a young child and is associated with rheumatic heart disease. Minor criteria, again, are minor, so they'll be mostly supporting things in the clinical vignette, and they're not specific for this disease. That's why they're minor. So watch out for fever. They have to have a fever. 100.4 or above is a fever. They may have arthralgia. Then they may have signs and symptoms of massive inflammation, which you see with high ESR and high CRP. Individual may also show signs and symptoms of heart block on the EKG. Clinical presentation for a person who have infective endocarditis, they may have signs and symptoms of what is called a Roth spot, kind of a coloration appearing in the eye, especially the white part of the eye. You may see Osler nodes. Osler nodes is painful nodes, things appear in a person's tips of the fingers. You may see Janeway lesions, which is also kind of a vasculitis type thing, but it's not painful. But Osler nodes are very painful. Let's look at a quick pathology here. There's an image here showing you the infective endocarditis that led to rheumatic heart fever that eventually led to this mitral valves to become very stenotic here. This is kind of a calcification type problems. And the next one here, and you can imagine in this individual, since this is an autopsy, you can imagine that their aortic valve is also at that level as well. In this next one here, you see in the person's mouth, you see that the person likely has strep throat. Again, this looks like a very young person, probably 16 years of age, 18 years of age. In terms of the management, you have prevention method, which you want to prevent strep throat from progressing any further. You can give anti-inflammatory like aspirins and such. You can give steroids in cases where the inflammation is severe, and then you can give antibiotic. If you're dealing with things like strep throat, you can give things like penicillin, sulfadiazine, and or erythromycin. So other important things here are the acute infection of the inner part of the heart. Usually staph areas will be the most common ones. Watch out for a person with IV drug use in a case, or watch out for a person who doesn't have any abnormal valve who presents with signs of infective endocarditis. Usually it has to be a very strong bug that can do that, and that's staph areas. In other cases, when a person have an abnormal valve where they have previous surgery or something like that, you're looking at the Viridin species, especially if the person has an oral surgery and they have infective endocarditis in the case. Ceftriaxone is a really good drug of choice for the Viridin species treatment. In other cases where a person may have an infection with strep bovis, infective endocarditis, you have to make a strong association with colorectal cancer. I want to make it very clear here that strep bovis is now called strep galacticus, and you will not see strep bovis anymore on the exam. You will see strep galacticus. Then you have the hay-sac organism also, which is associated with this infective endocarditis. Again, we spend just a very short time going over this because this stuff is not super high yield in terms of memorizing everything, but knowing your big picture stuff is what's going to get you the points you need when dealing specifically with endocarditis.